I certainly think tonight that you've seen some surprises. I think for a lot of people, the concept of having 70 million viremic infections, HCV infections globally is probably a little surprising, a little low. When we published the 80 million, it took about 2 years for people to start embracing it. What I would recommend is you embrace this quickly, because when we implement the WHO recommendations in 15 years, it's going to go down to 7 million. And it's going to happen pretty rapidly. And that's really the function of the Polaris Observatory. Because things are changing so quickly, we want to update this on an annual basis and track the number of treated patients. And I want to thank all of our collaborators who are sitting in the audience. When every 6 months we go back and we send them a long list of questions regarding how many people have been treated, diagnosed, what they've seen in terms of the prevalence, most recent prevalence estimate. And we're going to continue doing that, and we're going to continue to expand that over the next 15 years as elimination starts happening around these countries and we see a significant reduction in disease burden. And that's the price of success, right? We're going to see it fairly dramatic. And that's why we keep track of viremic infection rather than anti-HCV infection. Now, the best part of my job is working with incredible collaborators. You work with Dr. Waquette. I mean, we sit down with Western countries and they talk about treatment constraints. And the system cannot handle treating so many more patients. In Egypt, they're treating 200,000 people today. They're treating more people today in Egypt than all Europe combined, actually. When we work with Professor Razavi and his group in terms of the modeling and the work we're doing in terms of really innovative screening using phone calls, actually. And that's part of what we're doing is we're taking best practices from one country to another. And in China, the vaccination, hepatitis B vaccination, if it wasn't for the data from China, we wouldn't be able to drive and really develop the perinatal transmission. So that's the best part of our job, to work with a diverse group of people and just get to some fantastic data. The particular talk I'm going to give you, the economic impact, it was actually a request that came from Dr. Waquette in Egypt. And so he approached us and said, look, what we want to do is get an assessment of what is the economic impact of these strategies that we developed together in Egypt. And so we started developing a model that looked at not only the direct costs, but also the indirect costs associated with HCV. And of course, since then, it's actually been expanded, and now we've done the model with 14 countries. And every time we go through a new country, of course, there's new suggestions in terms of how to make the study better. And so this analysis continues to evolve. And the most recent analysis that was actually taken to the Parliament was the work we did with Nick Walsh in the Ripper region and from Mongolia. And it's not even listed up there. Sorry, Nick. I apologize. We missed some of the slides. Nick, you might just give me just a quick comment on the work in Mongolia and how it's driving decision making.
Sure. So I guess everyone knows the prevalence is high of Hep C in Mongolia, 6.8% of the general population viremic, so 200,000 people approximately. There was a lot of public interest in this because it really affected every family and overshadowed pretty much all of the other infectious diseases. So interestingly, key component of this was that the Vice Minister of Health at the time was a hepatologist. He had a PhD in hepatology. So he was very keen to do something about this, somewhat of a legacy. Anyway, the issue, and I guess we worked with Homie on this, was creating the idea that economically this was feasible. And there are two components to that. One was if you invest in treating or addressing hepatitis C at the population level, is that cost saving, or is it a good investment for society in general? So if you look at indirect costs, when you go for elimination, are you better off investing in elimination or not from a societal perspective? So the answer is yes, clearly. But the problem with that is that it's intangible. So what does the government say? Who's going to finance that? Well, we then had to go to the next level, which was really Okay, so what are the direct costs? So what we did with Homey was estimate. We had a couple of interns. They went, really facility to facility, collecting data on in the private and public sector. How much what does this cost? How much you out of pocket? How many people are using traditional medications to treat their liver disease? Ultimately, we came up with the figure 5% of the health insurance budget. Now, 98% of the population is covered by national health insurance. Was being spent on hepatitis C related infections, liver disease. And then we costed, so going for the elimination strategy, what would be the peak expenditure? It was very high. If you're going to treat a lot of people, it's going to cost a lot of money. Most of that's from the antiviral costs. So then, the finance, you've got the economic analysis, then you've got the financing component. Who's going to pay for it? Is it the individual? Is it the government? Is it the insurance, national insurance agency? So there was not going to be 100% domestic finance, unrealistic. So at what level do you have a co-payment? How do you calculate that? Well, we looked at the catastrophic health expense threshold, which is 40% of the lowest, 5% of the annual household expenditure, and we took that as maybe that could be the maximum of co-payment that a family or an individual might be able to afford, and factored that in. So if we factored this co-payment in, the direct costs to the financier were much less, significantly less, maybe 1/3 less. So that was good. But ultimately, when we did this approach, there was an investment needed, because if you don't spend money on cancer treatment, if you don't spend money on the management of end-stage liver disease, then obviously anything you do further is going to be not going to have a good return on investment, right? So there's an initial bonus payment. Ultimately, we worked collaboratively with the Ministry of Health and Sports. They put those two in the same ministry, and they wanted elimination, but they also wanted to reduce liver-related mortality. We combined these strategies so that over 15 years, you go for 5 years of treating people with advanced disease, then moving towards elimination over 10 years. And this actually, the data, the sort of strategy and the economic analysis was ultimately adopted by the government, by the ministry, and endorsed by the cabinet. And then it was actually endorsed by the parliament, which we felt was probably the most important component, because then it becomes almost above the political process. It's not one side nor the other. For those of you who know Mongolian politics, it's really important. So as a policy advocacy tool, we found it extremely effective. One thing that is apparent now is it was a little too conservative. Drug prices have come down faster. So I hope that's not too long.
No, that's fantastic, and you bring up a really good point. One of the issues we have as we go to different countries, and this is especially important in low-income countries, is this misconception about a $1,000 pill. The fact of the matter is 60% of the FC population today can't have access to generics. These are generics out of India, actually. And I was just talking to the Medicines Patent Pool, and they have just got licensed from a BMS, and about over 100 countries actually have access now to generic versions of the BMS's drug. The fact of the matter is, elimination is quite actually feasible, and we shouldn't stop wasting and talking about these high drug prices. In fact, no one is paying $80,000 for therapy. So what we wanted to do was really look at, because this was really driven by the perceived high cost, and we said, all right, so we need to actually look at the direct costs. So what are the components of direct costs? Well, first of all, there's healthcare costs, because the governments are going to be spending healthcare costs associated with liver cancer, cirrhosis, and we broke out outpatient, inpatient, medical costs, excluding HCV treatment, and we go from country to country and actually capture those. So that's one component. But then there's also the laboratory costs, and that's the cost of screening, PCR, viral load, staging, genotyping. And believe it or not, these costs can really add up, and they're quite actually expensive. So that's the second component, and then we add to that the current treatment costs, which is typically pegylated interferon or standard interferon in some countries, and as Nick had mentioned, also traditional medicine. and then really put that side by side with the future cost of therapies. And so those are all captured. Now, it also gets more complex because not all countries are under a public system, so we have to take into account that some portion of the population is using a private system, and also there's co-pays associated, especially when there's a private. So those are the direct costs, right? So pretty easy to understand. We know, using the modeling that you saw, we know what the disease burden is going to happen in the future, how much HCC is going to increase, so we could actually calculate that fairly easily. But Professor Waked came back and said, look, that's not the only thing. That when you have HCV infection, you also lose productivity, and you also have a shorter life expectancy because you're dying of liver. And so we actually went back, and this is Chris Estes, who's in the back there, developed the algorithms for years living with disability and years life and life lost, and then we convert that to economic value using the GNI actually, per capita, but not for all ages, only for working ages, so older than 20 and younger than 65. And so that makes a big difference when you look at the populations when they're much older, because the indirect cost actually disappears. The other issue we run into is when you start working in Africa, where they have very low income, national income per capita, the indirect cost impact is actually significantly lower. And then what we did was we looked at different scenarios. So what if we look at WHO recommendation of elimination? A lot of the countries also went to look at the drop in generic prices over time. And in fact, that's become a reality. It's actually dropping much faster than we had anticipated when we developed the original models. And then the more important was what would be the impact of simplifying laboratory procedure. And I'm going to show you an example of the work we did in Ethiopia, actually. So in Ethiopia, the anti-HCV cost in the public sector, this is for just diagnostics, $13. RNA test is about 120, genotyping about 70, and staging fibroscan is about 250. And of course, substantially more expensive in private setting. Now, they actually send samples all the way to Germany. There are private labs in Ethiopia, but they're not fully utilized, and they tend to be expensive because they are trying to cover margins. So the ministry actually, there's a substantial portion of these samples and tests that are sent over to Germany. And in other African countries, they actually send it all the way to South Africa. Bit of a problem. And so if you add up numbers in terms of recurrent therapy, they have to run 5 RNA tests to do viral loads, anti-HCV, genotyping. In fact, the cost of just laboratory tests is around $1,200. Now remember, we're talking about cost of treatment that's less than $1,000. And in fact, it's going to go down to $240 ultimately. So in fact, what we're finding is in low-income countries and where generic drugs are available, the diagnostic costs are actually turning out to be much higher than the treatment costs. Now, what about if you don't treat someone? Of course, the annual follow-up cost is about $600. Compensated cirrhosis is about $680, so not substantially more. And then decomp and carcinoma are slightly higher. And unfortunately, the mortality rate in Ethiopia is quite high because there's not a lot of chemotherapy, there's not a lot of procedures done for HCC patients, and liver transplant is almost non-existent unless someone's wealthy enough to leave the country to get liver transplants. So we started looking actually at the cost. So there's a lot of graphs here. What we're showing on the bottom is the year, starting with 2015, and then all the costs are reported in US dollars actually. So what's interesting is if we look at the treatment, and then the laboratory costs associated with treatment, we're talking about, it starts going up of about 16 million, and then it starts coming down as we continue to treat. And part of the reason it's coming down is in this portion. Although we're treating more patients, the cost of generics is going down. So that's captured. What was really surprising is, and I want you to take a look at this scale. So now we're talking about 70 million for screening versus 16 million for treatment and lab costs. And this is part of the issue that we're running into with low prevalence countries with low diagnosis rate. Is in order to actually find these individuals, you're going to have to screen a lot of people. And I think there's some real innovation that's required here in terms of pooling blood samples to reduce costs in order to find positive cases, because obviously this is not something that's sustainable. Now, what we did was we summed these together. Oh, what we did, we also looked at the total healthcare costs. So the black line is under the base scenario, the current scenario. And of course, as you would expect, as the disease burden increases, you see an increase in healthcare costs. And what was interesting in Ethiopia is because there's such low diagnosis rate, as you start diagnosing people, all of a sudden you're finding people with HCC, decompensated cirrhosis. And in fact, initially, your healthcare cost goes up because now therefore people just die. But now you know about it and you can actually hospitalize them. But then as you start treating, of course, and you see the impact of the elimination, you see that the healthcare cost drops substantially. So great news, right? So you're going to have a reduction in healthcare costs, and that's offset by the treatment and screening. And in fact, when you sum those together, what you see is initial expenditure. But then after 2027, you see a substantial drop. And this is in Ethiopia, right? Where they're not spending a lot on healthcare already. So from a government's perspective, what they're really interested is the total expenditure, so the cumulative. Now, what we also want to do is look at the indirect costs. So we looked at DALYs, and of course, as you start curing people, the disability-adjusted life years drop significantly. So that's great news. But if you look at the cost, of course, that cost will drop. We're really talking about 10 million. The GNI per capita is quite low. So even though you see a fairly substantial drop in DALY, the indirect cost impact of that is quite small. So we're talking about 15 million a year. So when you sum the direct and indirect costs in Ethiopia, the overall shape actually was quite similar to what you saw before. So then we took that and we actually developed a graph of cumulatively what the government would spend. Of course, cumulatively on HCV, under the base scenario, would increase quite rapidly. But take a look what happens when you start looking at the elimination strategy. So initially, the government will spend more, but actually after 2032, they break even, and now it's actually cost saving, right? So the delta between this is money that the government is saving. They would have spent it before, actually, and they're not actually spending it. So you can do a financial analysis on it, and you can look at return on investment. So in fact, treating these patients and going after achieving WHO elimination has a negative return on investment. So you lose money, but you lose less. And then all of a sudden, 2032, it becomes positive. And now, on the initial, the cumulative investments you have, you get almost more than 3-to-1 return. That's pretty attractive, right? So we're not talking about treatment being cost effective. We're actually talking about cost saving. And in fact, having a positive return on investment in less than 15 years. So that was an outlier. And we had done the work in Mongolia, and we started looking at different countries. And in fact, what we saw was consistently the same analysis. So this was the work we had completed with Dr. Wickett and his team. And under the status quo, so this was if we continue to treat with pega interferon, you would see very similarly an increase in total cost. This is total direct and indirect costs. And in fact, when you look at the elimination, there's only 1 year where the cost is higher, and in every other year, it turns out it's actually less expensive to treat lyme. And of course, we saw similar effects in Mongolia. This is the work that Nick mentioned. So black line again, the status quo, and the green line is the elimination, similar to WHO, and in fact, only 1 year, and this is where we had to do a massive screening to find people. After that, you actually see that it costs less. Annual cost is actually, total direct and indirect cost is substantially less. So we kind of scratch our head and go, well, maybe this is an outlier, right? Because a lot of these countries are getting access to generics, so let's take a look at a country where they have to pay full price. So we were fortunate to have a really good relationship with the Ministry of Health in Saudi Arabia, and then we started working with them. And Saudi Arabia is pretty paying pretty decent prices for their drugs. And in fact, the analysis is even more attractive, which would surprise us. So why would that be? Well, it turns out healthcare costs are substantially more expensive in high-income countries, right? So Saudis actually spend a lot more. So if you look at total direct and indirect costs, of course it would increase as a disease burden. And once you go after elimination, of course you break even. So if you look at the ROI, there's actually only 3 years that the salaries would actually have a negative return on investment. And after about 3 years, it actually goes positive, and they actually, it's considerably positive. So we said, look, maybe this whole direct indirect is costs. So let's take a look at direct costs. And in fact, if you only look at what the Ministry of Health will be spending, they'll actually break even after 2027. And we've done this country after country after country. In every case, we've seen cost saving. We're not talking about cost effective. These are actually much less costly over a 15 period than doing nothing. So the point of the message of these studies has been the fact that the government will be spending this money no matter what. And so all we're asking for them is to spend it a little sooner and get substantial cost savings. But the problem is not that simple. And this is what happened in Mongolia. So as we work with the Ministry of Health, what they're spending now is about 5% of the public health insurance. So to achieve elimination, and we show that over a 15-year period, they can actually save money, right? But in order to do that, they're going to have to spend about 18% of their public health insurance by 2018 to be able to do that. And this is the fundamental issue. It's not that the drugs are too expensive. It's the fact that they have to spend a lot more to save a lot more money later. So one of the things, the moral was that negotiating direct prices is important. Look, I think you need, at the national level, you need to make sure that you get the price that's fair. But the central issue facing HCV elimination is how to pay for it now and recover the investment later. This is the critical point. And I think that's one of the models that one of the things we're developing is a hepatitis fund now to raise money to help countries actually pay for this. So they actually do a fixed payment over a period of time, but they get as much drugs and diagnostics as they need in order to achieve the elimination. So in conclusion, what I want to highlight, and this is often lost in the different messages, 60% of all HCV infected can have access to generic DAs. And I say can. Why? Because governments have regulatory approval, they need clinical trials, so they can have it, except that there are barriers, and if they're approved, they can get it today. And the manufacturers, the original manufacturers, do not control the pricing. So BMS, Gilead does not control the prices. It's 60% of all of these. So there's over 101 in Gilead, and the BMS is about 110. Now, in order to determine what's the fair pricing, what we need is good healthcare and diagnostic costs to estimate the economic burden and cost effectiveness. All of these are now offered for free to all countries as part of the Polaris. So if you have data, you're interested, we'd love to run the analysis with you, as well as the disease burden and the hepatitis B and the peritoneal transmission. So the laboratory and testing requirement for HCV treatment needs to be simplified. Look, I think there's been such a focus on the cost of treatment that we're forgetting the cost of screening, and this is going to be critical. And that's what's going to be the next bottleneck. We need to eliminate steps. We need to combine blood samples to. So PCR test is about 10 times more expensive than anti-HCV. When you go to Africa, the anti-HCV is quite high, but if you look at percent rate, it's quite low. And so there may be spontaneous clearance, there may be another reason, but our recommendation is to skip anti-HCV completely and going forward, really just going with PCR and pool blood samples in order to reduce the cost. So if you pool the blood of 10 people together and run a PCR, that's about the same price as running one anti-HCV. And it needs to be simplified if you can do a core antigen test. The cost of diagnostic needs to be examined closely in low-income countries. This is a huge area right now, and the central issue facing HCV elimination is how to pay for it now, knowing that actually over the next 15 years the countries will recover from the investment. So I'm going to stop there and open it up for questions. Thank you so much.